September 2025. Could I just go through these minutes just to check accuracy? If you could raise your hand if there are any points that you want to raise on the board minutes. Page 1, page 2, page 3. I don't see any dissenting hands there, so we'll accept those as a true reflection of our meeting. We're moving on now onto matters arising. Debbie, children and adolescent mental health services. There was an issue that you were going to feed back on.
No, the
Is it?
issue was basically arranging this meeting
Oh,
for
right. Okay.
CAMHS to come, so
That's
that's done now.
that's done. Well
Yeah,
done.
thank you.
The next item was ADHD services. Again, Debbie.
Yeah, there's not any other update at the moment. I think I said last time that the ICB had accredited both adult and children providers under the Right to Choose scheme. And providing patients use those, they will be able to get shared care for medication. But if you don't use those, GPs aren't going to agree to the shared care. And also you're risking your diagnosis not being accepted by health or potentially education. But all GPs are now aware of it. And we've been working with the ICB to design a patient publication so that patients know exactly the route to go for both autism and ADHD. But that's yet to be published yet. So obviously we'll update you when that happens.
Thank you. Chris, Healthwatch Worcestershire's position statement on prostate cancer.
Yeah, thank you, Don. Just a brief summary of the background. As you will probably know, prostate cancer is the most common cause of cancer for men in the UK. Kills about 12,000 men a year. And from previous surveys, we've found that there's an inconsistent response amongst GPs when men inquire about prostate cancer and PSA testing within the county, which also reflects the same issue across the country as well. We've previously reported this to the ICB, and we've had reassurances back from the ICB that they've spoken to the GP practices within the county to reassure us that men will get a better response. Now, we've done a follow-up on that and found, sadly, that that's not the case. So we've produced a report. It's called the Healthwatch Worcestershire Position Statement on Prostate Cancer PSA Testing, which is available on our website for people to look at. We've communicated that back to the ICB, and we're in the process of working with them to reduce the variability. The other thing that has occurred as well is that the UK National Screening Committee towards the end of November last year produced a draft report on how they would like to actually screen for prostate cancer. So the draft recommendations currently are to identify the BRCA1 and BRCA2 genes of men who are at high risk of prostate cancer. This is essentially on the female line, basically the mothers of men who've had breast cancer. Now, that's a very small percentage of men across the country, and a lot of probably all of the national prostate cancer charity groups disagree with that. And it leaves a lot of high-risk men underserved by these particular recommendations. So what we are doing about it locally in Worcestershire is we're working with the Worcester Prostate Cancer Support Group to actually write up our own local response back to these particular recommendations, highlighting the fact that Black men in particular are at high risk of prostate cancer. So, for example, men of my age are at risk of prostate cancer. 1 in 8 of us are at risk. Black men, 1 in 4, And if their fathers have had prostate cancer, that's 1 in 2. So you think about that for a bit. 1 in 2 black men, if their fathers have had prostate cancer, are at very high risk of developing prostate cancer. Now, that means, of course, that there's a lot of men out there who are not being picked up. So what we're doing is we have produced a survey, which is going to be published fairly soon. It'll be available on our social media websites, and through the Worcestershire Prostate Cancer Support Group for men in the county, and people who care for the men in our county to fill in and give us some more information that we can add into the report that we're putting together with the Worcestershire Prostate Cancer Support Group, as our response back to their draft recommendations. So just a piece of information there on that. So that's what we're doing about it at the moment. Thank you, Don.
Thank you, Chris. Are there any questions on that issue? No, thank you. We'll move on to item 4 on the agenda. Adult Community Mental Health Services report. Vicky.
Yeah, so I'm bringing this to board for final approval. It was enclosure number 2, which was distributed with the agenda. We're currently waiting for the ICB to give us their response, and I was advised that they wouldn't have it ready for this meeting, but hopefully we'll get it for the next one. So it's already received a virtual sign-off by directors. So we're just looking for final approval at this meeting, Don. Thank you.
So do we have final approval on this meeting? Yeah. Good, thank you. And item 5, how patients access NH information.
Yeah, again, same for this one. So this has already been through the closed board meeting and been approved, but I'm bringing it to the public board meeting now for consideration and approval.
Again, do we approve that?
Okay, yeah.
Yeah, I'm getting nods. Good, thank you.
Thanks, Don.
Item 6, relevant decision, enter and view, Chris.
Yeah, so again, just to give you some background on this, we've agreed with the chief nurse at the Worcester Acute Hospital to do a site visit for the emergency department units at the Worcester Acute and at the Alex. As all of you well know, there's a problem with the numbers of patients that go through the A&E departments. We've got issues with corridor care, which has been in the press quite recently, obviously, due to the volume of patients actually going through the system and how they're actually looked after. And we had the chief nurse at our recent autumn conference just before Christmas there, where she was talking about the flow of patients going into the hospital. And of course, one of the other questions that comes from that is some patients probably are better served by going elsewhere rather than going into A&E. So the purpose of the visits that we've got with the Alex and at the Worcester Acute is to get closer to the problems and find out from the horse's mouth, as it were, what the acute are doing about this. We'll be writing a report about it and reporting back on our website what we find. But in order to do that, we need to do this under our statutory powers of enter and view. And as a result of that, we need to make a public record of who's going to be leading the exercise. So can you please make a note, Don, that Julia North and myself, Chris Byrne, will be leading the enter and view from on the behalf of Healthwatch Worcestershire as we meet the people at the hospital there. In addition, should anybody become sick or we need to make additions to the group of people going to the hospital working on behalf of Healthwatch Worcestershire, that will be recorded and published on our website as well. So it's a matter of form really for that. We would welcome any questions from the public in terms of what the public would like us to raise. At the moment, our draft objectives are going to be corridor care, discharge, pharmacy, medication, as well as waiting times on ambulances. So those are the kind of main themes that we're looking at the moment. And if the public wants us to actually add anything else, please can they contact us and we'll put it on the list. Thank you, Don.
Chris, sorry, what's the date of that visit? Forgive me.
Yeah, good question. I forgot to say, we aim to do the 2 visits, one for the Alex and one for the Worcester Acute on 2 occasions, and we're looking towards the end of February. We haven't agreed the dates yet because we need to actually get all the diaries together, but that's what we're aiming to do towards the end of February.
Can you confirm that quite quickly, Chris, on to get in the diary?
Yeah, so that's work in progress, and we aim to do that quite quickly. Yes.
Yeah, I'd like to be involved in that if possible, yeah.
Okay, we'll talk to you offline then. Thank you.
Thanks, Chris. Okay.
Thank you. Item 7, organisational update. Vicky.
Thank you. Well, this is all about the team, because since our last public board meeting, which I think was back in September, we've had lots of team changes. First of all, I just want to publicly thank our former senior engagement officers, Margaret Riley and Susie James, who have over the last few months left the organisation. Between them, they have given nearly 20 years of service to Healthwatch Worcestershire, and I just want to publicly acknowledge that and thank them for their work. And then I would like to give a warm welcome to a new member of the team, Abby Jane, who joins us as an engagement officer. Abby's on call tonight. This is her first public board meeting. Abby comes to us. She's got a wealth of experience in working with children and young people. She's got digital skills and she's got lots of energy and is really good at engaging with people. So I'm hoping that her split skills of engagement and digital will bring more feedback to Healthwatch Worcestershire. So welcome, Abby. And just to say, if you haven't met Jay, she's our other engagement officer, Jay Panu. She's only been with us 4 months. And she's still here, so she must be liking it. And just one more mention I want to say about the team. Helen Wood, who is our administration officer, she is the wheels that keep us in motion, and she'll be celebrating 10 years with us next week on the 20th of January, I think. So although she's not here, I just want to thank her for all the work she does for us and just give some public acknowledgement to her 10 years of service to Healthwatch Worcestershire. So thank you, and thanks to all the team for their work. Thanks, Don.
Well, welcome, Abby. Look forward to working with you soon. Yeah.
Yes, welcome, Abby.
Thank you. As you can see from the fact that we are recruiting, it's business as usual at Healthwatch Worcestershire. I'm just going to give you a bit of an indication of it comes under the heading closure update. We're currently attending various meetings to ensure that there remains a public voice and representation after the dissolution of Healthwatch Worcestershire. We've got various meetings coming up. We've been to various meetings. We've got meetings with Simon Trickett, the Chief Officer of the Coventry and Warwickshire and Hereford and Worcestershire Integrated Care Board. We've got a meeting coming up with the Department of Health and Social Care, and we're hoping to get an idea of the future. What will replace Healthwatch? As I was saying, until we are dissolved, we will continue to represent the people of Worcestershire and challenging health and social services where necessary and attending various meetings. and basically we will keep you informed of developments as soon as we find out what's going on and what is going to replace Healthwatch Worcestershire into the future. But it is a time of change for all parts of the health service and social services. So please bear with us. We are a little bit early, but we're now going to move on to section 8, the CAMHS question and answer session. I guess there may be people who join us as we progress in this section. As I said before, if we could please mute our microphones when we're not speaking. Please respect our guests and each other. I'm sure there are. This is a subject that is close to very many people's hearts on this call. We are recording this meeting, so please don't share anything that is confidential and that would cause us GDPR issues. We must not mention any personal experiences on this call. So, bearing that in mind, can I invite the representatives of the ICB and Herefordshire and Worcestershire Healthcare Trust to introduce themselves? It's probably best for you to introduce yourselves rather than me try and do it badly.
Excellent. Okay. So my name's Scott Parker. I'm Director of Operations and Transformation in Herefordshire and Worcestershire Health and Care Trust. If Sonia and Katie introduce themselves, then I'll cover off the ICB bit.
Hi, good evening, everyone. My name's Sonia Upton. So I'm the Associate Director for Children, Young People and Families and Specialist Primary Care. So I lead in Worcestershire on all things for CAMHS, for 0 to 19, so public health, nursing, school nursing services, and our community paediatric services.
Thanks, Sonia, and evening, everyone. My name is Katie, Dr. Katie Powell. I'm a CAMHS consultant psychiatrist by trade, and I am Sonia's counterpart, but I am the Associate Medical Director for our Children's Services.
Now, we were going to be, as you've probably seen from the agenda, Mary from the ICB was going to be joining us. Unfortunately, she's still travelling on the M40, so I'm going to try and do the ICB part of this as well as we go through.
Thank you. We're now going to move over to the questions that will come up on the screen, and we will.
I just wonder would it be helpful if we just do a really quick overview of what the service offer is in Worcestershire, and then that'll actually help contextualise some of the questions. So if Sonia, Katie, can I hand over to you and just do us a little introduction?
Yeah, sure. So CAMHS stands for Child and Adolescent Mental Health Services, and it's a specialist service really run by the health service to provide a therapy and support to children and young people up to age 18 with severe and enduring mental health needs. So I think, Katie, you sometimes describe this, don't you, as about mental illness. So what we mean by that is conditions such as anorexia nervosa, bulimia nervosa, depression, OCD, psychosis, a whole range of mental health conditions that require specialist intervention and treatment. We also provide a range of services, some that are called CAMHS and some that aren't, and the ICB commission a range of services. So a bit like physical health is, everyone's business to think about how do we have good physical health. Good emotional and mental health comes from a range of services for children. So we provide mental health support teams in schools. We're in about 60% of schools now with national funding. And with that funding continuing, the plan from the government is that we'll be in 100% of schools by 2030. There are also services like Mellow in Worcestershire, Cooth and Luminova, so a range of services that think about emotional health and well-being, as well as that specialist CAMHS service that's about treating people's severe and enduring mental illness. We've also got around us a range of services like 0 to 19, so that's school nursing, and we work with the family hubs that do provide support for people up to age 19 or 25 if they're young people with SEND and their parent carers. So we're part of a wider system across health, education, social care, and CAMHS is the bit that we're talking about, which is about that kind of severe and enduring mental illness. Anything I've missed, Katie? Anything you want to add to that?
No, I think that's exactly spot on, Sonia. I think I sometimes think we have a somewhat unfortunate name with CAMHS because, as you described, CAMHS in our health board describes the very sort of specific, old-fashioned, if you like, tier 3, highly specialised service for young people who had a moderate or severe mental illness, like the conditions that Sonia listed, rather than, and then you've got the wider CAMHS offer, which includes our colleagues such as kind of Mellow and Cooth and things like that, which more broadly would kind of support with emotional, mental health and well-being. And I think it's important, Sonia says, to remember that, you know, we all have mental health the same as we have physical health. And thankfully, the general principles for looking after your mental health are largely the same as looking after your physical health. So it's eating well, drinking enough water, getting enough sleep, getting out in the fresh air, getting off our devices a little bit more, that kind of thing. You know, so there's loads of stuff we can do to really foster good, solid mental health. And thankfully, very few children actually need to come through to our highly specialist CAMHS service because thankfully, very few children actually have a moderate to severe mental illness.
Thank you both. So, Chair, that's probably serves as a quite helpful introduction, and we can perhaps go into some of the questions.
Yeah. Vicky, are you going to put the questions up?
I'll just share my screen.
We're going to go. Yeah, thank you. We're going to go through these questions that page by page. They are linked on each page, and there are various sections to each of the
Can you see them?
Not yet.
Oh, okay, just bear with me.
No. Yeah, Chair, perhaps what I'll do, just whilst we're getting set up there, where I've got the written answers from commissioning colleagues, I'll just make it clear when I'm reading those out that's the commissioning viewpoint.
Thank you.
Shall I go to the first question?
Yes, please.
So what we've tried to do, because we did have an awful lot of questions emailed into us, so although we've listed all of them here within this set of slides, I've tried to put them into themes. So I'll read through all of the ones on this first slide, and then you can answer then. So the first one was, why is it that lots of children and teens in Worcestershire that are neurodivergent are being refused to be treated by CAMHS and diverted elsewhere to a service that cannot meet their mental health needs? Can CAMHS please confirm if they are commissioned to help and support a young person with a diagnosis of autism? If they are not, can you please confirm why this is not made perfectly clear at the time of referral and why there is a wait of months and months for an assessment when it is very evident there is no treatment for a young person with such a diagnosis and the outcome of the referral is predetermined before the assessment appointment has taken place? Why isn't the referral refused in the beginning if there is no treatment for someone with autism? I would also like to know whether this totally unethical decision sits within disability discrimination under the Equality Act. I would like to ask the ICB what the ICB intend to do about the long-term gap in mental health support, particularly for neurodivergent children and young people, especially as these children and young people now have additional trauma and issues exacerbated by years of no support, therapies, interventions, or even hope offered or available from any mental health services.
Okay, shall I start a bit of a response to that, and then hopefully Katie, as our consultant psychiatrist, or Scott can jump in for anything that I might have missed. So, as I described, CAMHS is designed to provide that kind of therapeutic intervention to children and young people with a mental illness. So those children with severe complex mental health need. And our staff are then trained to provide therapeutic interventions, so evidence-based treatment for those conditions like anorexia or anxiety and depression and so on. And that helps our children and young people to recover from that mental illness and get on with other things that are far more interesting and live their best lives. So we accept people into CAMHS who would benefit from what we can offer to help them with their mental health need. We do also provide crisis services 24/7 for children in mental health crisis. Autism spectrum condition, it is not a mental health illness. And if you are if you are diagnosed with autism, you're not experiencing a mental health illness. It's called a condition, a neurodivergent condition. It's not something that requires treatment. It's not something that you recover from. But children with neurodivergent conditions might need support in how they live with a condition. So that can include how you change the environment, how you parent that young person or child. It can include communication or different ways of how you live with that condition for the rest of your life. It's not something that's seen as a mental illness or something that you have treatment and recovery from. So that's the difference. So sometimes people might be referred to CAMHS and the presentation, what they're presenting with is a neurodivergent condition and not a mental illness. So they wouldn't benefit from what CAMHS can offer in that sense. However, if a child with a neurodivergent condition also has a mental health illness or need, a condition that would benefit from CAMHS service, those children are accepted. They would be seen in CAMHS. And we've done a recent review. About 30% of children on the overall caseload in CAMHS have a neurodivergent condition. There are more accessing our crisis service. That goes up to about 60%. But yes, children aren't refused, and we've done a lot of training with our staff to ensure that those mental health therapies and interventions can be adapted for children with a neurodivergent need. We've done something called the Anna Freud training, which includes parents and carers with experience, helping staff learn how to communicate, engage, change the environment, think about how we adapt our therapy for those young people. I don't know, Scott, if you want to come in for the ICB question.
Can I just ask one thing, Sonia? I think where this question comes from, because we get a lot of feedback, as you well know, about this, is I suppose it's the way the rejection letters are worded, because it often refers to ASD as if that's the reason why they haven't been accepted to CAMHS. And I think that's where people assume then, and it also seems to be that often it's not accepted that you can have ASD and a mental health issue. It seems to be that they're always like lumped together almost.
Yeah, so I think historically we weren't very good at really being clear about that, Debbie, and we have done a whole heap of work on our referral letters. I think people try and be helpful in signposting, and it can come across by saying we're not accepting you because of your neurodivergence, rather than you have a neurodivergent condition rather than a mental health condition and illness, and we don't think you would benefit from CAMHS. So yeah, we've done work on that. We're constantly looking to improve how we write letters, how we signpost. We're really keen to have any feedback, and we're looking to carry on improving that as we go. We've also developed a new website that's launching in April, and that's had a lot of feedback from people that use our services, young people, children and parents, carers, to try and make it easier to navigate. How do you find what you need quickly and easily. So we're really excited that that's going to hopefully be another helpful resource for people in Worcestershire.
Thank you. And okay, so obviously I do not work for Hereford and Worcester ICB, but unfortunately Mary, who was going to be here, she's unfortunately stuck in transit on the M40 at the moment. But the team over at the ICB have been able to provide a number of answers here for questions. So what I'll do is I will just read it out so that I make sure that I make sure that I get the context correct for everybody. So this is going to the last question there, which was around, I'd like to ask what the ICB intends to do about the long-term gap in mental health support, particularly for neurodiverse CYPD. So the response, I've got a couple of paragraphs here which are quite helpful. And also it does lean into what Katie was talking about earlier on and what Sonia was talking about. So it starts with, we're working with Hereford and Worcester Health and Care Trust to look at support for children and young people with neurodiversity and with LD, and also working with our county council colleagues. We want to have a model for children and young people that identifies early need and makes access to support timely and effective. In the last year, we have made changes. We have expanded the children and young people service with mental health. So for lower levels of need, so for instance, Lumina Nova and Mellow, to offer earlier interventions. These services are working in partnership with CAMHS. This will give us a model of no wrong door. So what that means is that we're working together with those services to make sure that if a referral comes in, it will be directed to the most appropriate service and people won't be bounced backwards and forwards throughout the system. The next areas, as Sonia picked up, was around the service that we do actually provide, and some of these stats have already been provided. So in terms of the mental health schools teams, we're on course to hit the target of 100% coverage by 2030. Obviously, that's subject to the government funding continuing. Under 18 mental health and emotional wellbeing access levels in Hereford, Worcester is now above the target set by NHS England. So that's over 12,000 children in the last 12 months. And again, what that's saying is that so as a commissioner and as a provider, we've supported more children than we're intended to by this time with this funding, and we'll carry on with that progress. That's actually stepped up significantly by about 25% year on year. The ICB has commissioned a 0 to 25 neurodiversity support services to start in July 2026. And that will mean that CAMHS, which has been the go-to service for all mental health issues for under 18s, can focus on supporting and treating children with a severe and enduring mental illness or who are in crisis. So when you combine what the commissioner's intention is and us as a provider, what it's about is a joined up system where whichever route you go in, you will get supported to get to the right destination. And as you can see, there is funding available and funding coming through to support young people in Worcestershire. Now, whilst it's these services, we're not meeting demand at this stage. We are continuing to invest, continuing to recruit, and continuing to train up our services to make sure we can support people appropriately.
I've got a question from the comments. If I can place those, please. Don, is that okay?
Yes, please. Yeah.
Yeah. Okay. So I think the one that I'd like to start with is from Dawn. Without doing an assessment, how can you determine what is a neurodivergent issue and what is a mental health issue? Building on that, Tracy says, if CAMHS are not the service to support neurodivergent people with maintaining mental health, the commissioning gap needs to be addressed. And of those who have received emergency treatment, Sonia, I think you said 60% of emergency cases were neurodivergent. Have any of those been previously refused by CAMHS for non-urgent treatment. So it looks like there's this gap here that people are talking about. Could you address that, please?
Okay, so in terms of the assessment question, so if Katie, that probably feels like an area for your expertise. In terms of commissioning gaps, again, obviously we haven't got the commissioner here, but I'll try and just have a little look through the questions and try to talk to those after.
Yeah, sure. So I think all referrals that come into CAMHS come into a single point of access, a SPA team, and we have an MDT, we have a multidisciplinary team who screen through all of the referrals. All our referrals are screened sort of within 24 hours of landing, and all of those clinicians who make up that MDT are band 6 or above. So there's some of our most experienced CAMHS clinicians. I guess as part of the training, you get very used to kind of identifying key points, if you like, of information in referrals where it sort of becomes very apparent. I think it's quite we sort of screen for reasonable suspicion of moderate to severe mental illness in our CAMHS team. And if we don't think that the young person quite hits the threshold for our service, then we will make recommendations for the service that we think will best meet their needs. So I think it is an experience, and it is a team decision. It's never one person on their own. So we sort of, try to mitigate that, to make sure that our screening is as accurate as possible.
Okay. I mean, so picking up some of the questions around the commissioning gaps, like I say, I am not the commissioner, so it's I could just talk around things that I'm aware of that are going on. So, as I say, that there is a wide range of investment going into children and young people's mental health. There has been a big increase in demand since COVID, and this is a national picture. As a number of you around the table also sit on various other boards. There's a lot of the conversations around. There's some funding coming into the council, for instance, which is looking at supporting people who, whilst they don't have meet the threshold for CAMHS. There is then some additional support for those young people. So I think that the reassurance that I can give is that these gaps or challenges in access, they are understood. The guarantee I can give you for services which sit within Herefordshire and Worcester Health and Care Trust will work very, very hard to make sure that we support as many young people as possible. But also make it as easy as possible to navigate services. And that's a continual piece of work we have. Were there any other ones on there? I mean, there's, so just pick up one of the ones. If CAMHS are not the service to support, so all children and young people could access support with services such as Mellow Cooth, the mental health schools team. These are all services which are specifically commissioned within Worcestershire to support people who do not meet the CAMHS threshold. So again, those are the services which are on offer in this in the county.
Could I also raise the question that's been put in the comments around young people who have suicide ideation? Are they being correctly served, I guess, is the question that I'm looking at here. So, for example, Anne says if regular suicide attempts do not meet moderate to severe criteria, what does?
So Katie might want to come in on this, but I'm happy to start. I think one of the issues is that there can be lots of reasons for children to behave in ways that put themselves or other people at risk. Sometimes that can be about mental health needs. Sometimes it can be about other things that are happening in their lives. It can be about a way of communicating. It can be due to having a learning disability, or a range of different ways that children might behave and express their needs. We would really encourage people to reach out for support if they've got concerns about the safety of their child or themselves. So our CAMHS crisis team is available 24/7, so people can access support around mental health crisis. We would encourage people to phone 111, phone 999, social care, emergency response, the police, go to the ED department. There are a range of emergency services out there to help you in a crisis. And our review of our CAMHS service really indicates that our crisis team is accepting children with neurodiversity when they have a mental health crisis. So we have got some assurance from that data of 60% that children are accessing in that when they need to. But we would encourage people to reach out for that help when they need it.
So,
sorry.
Yeah, if I can just kind of ask a supplementary question on that, please, around what happens then at 3 o'clock in the morning if a young person requires medication and they've had a couple of suicide attempts that evening. What's the best route for that parent to help that particular child?
So I can take this one if you like, guys, because part of my day job is that I work as a consultant in the CAMHS crisis team. So at 3 o'clock in the morning, absolute, if the young person has attempted to significantly hurt themselves, or as you said, Chris, suicide attempt, we'd recommend at that point that the family present the child to A&E, where they would almost certainly get admitted to the children's ward, where they could be kept safe overnight, and then the following day an assessment would take place with our CAMHS crisis team, and we would be able to have a good understanding of what that young person needs. If emergency medication was then required, my colleagues on the paediatric ward, they have a bespoke kind of flow chart, if you like, of emergency medications that they can give if needed if children are significantly heightened, that they're putting themselves at risk. So they're always able to access that.
Okay, thank you. We've got a question from Bernie. And then Anne, can you please not mention anything personal? Thank you. Bernie, you first.
Hiya, thank you. Yeah, I'm asking this obviously as the co-chair of the Parent Carer Forum, but as a lived experience expert as well of autism and mental health conditions. So I've got a couple of questions actually, which I didn't realise I needed to get in because this has all been a bit last minute. But first of all, just regarding that suicide ideation thing, I need people to stop calling it neurodiversity. It's neurodivergence. Everyone's neurodiverse. We're all diverse. Divergence is when we diverge from the norm. So that's the terminology that should be being used. And secondly, the work of Dr. Sarah Cassidy shows that autism and suicide are far higher triggers and there is a much higher risk factor with autistic people actually completing suicide. So when we're talking about suicide ideation, and these are behaviours that people are expressing themselves through, I just want to raise the research evidence base that shows that autism and suicide are very closely connected. So that's the one thing, just to put that little bit out there. The other issues that I've got that are sort of separate from that, you sort of mentioned that that CAMHS in particular is for moderate to severe mental illnesses, and you actually quoted OCD. Now, what is the experience that I've been made aware of is that OCD is being often dismissed as autism, and the sort of sticky thoughts and the sort of obsessive processes that people with autism go through, so actually aren't even able to get onto the referrals. When they have been referred, they've been kicked back off the referrals. So it's just been thrown back because the consideration is that it is autism. So that sort of contradicts what's been said earlier on about these level 6 professionals kind of being able to pick out the differences, because ultimately if a child presents with OCD of any version and it is debilitating, autism or not, they still need that OCD fixing. I know a lot of autistic people with traits of OCD. Then I know people who have got very severe OCD, and that's not the hand washing and that's not the checking the cookers off. These are intrusive thoughts that completely take over somebody's life, child and adult. So I'm sort of concerned that there's not an actual direct pathway there. And of course, if you're an adult and you go to the community mental health team and get seen by a psychiatrist, you are medicated for that. CBT doesn't work, especially if you're autistic. Then that's one process. As a child, that's just never on the cards. It's CBT which doesn't work. And the general sort of guidance is all about talk therapies and working through it. But as we know, those sorts of traditional therapies don't work with autistic people. So I'm at a loss really as to what the proper pathway is for a child who does happen to have an autism diagnosis, which then exacerbates the OCD, and maybe the OCD exacerbates their autism symptoms to the point where they want to die, so it's all kind of connected and sort of intertwined there. So there doesn't seem to be a clear pathway to access mental health for that moderate to severe mental illness. And then similarly with Tourette's syndrome. So again, it's all about other therapeutic methods, whereas actually all of the therapeutic methods may well have been exhausted, but medication is the only option. And again, if you cannot see a psychiatrist for what could be quite low level medication, you can't get that, you are debilitated, yet there's no direct pathway. And again, from experience, children who are referred, the referral gets looked at and peculiar letters come back out saying that, it's something around autism. And it's got nothing to do with autism. It's got absolutely nothing to do with autism, that they don't meet a threshold for mental health issues when there is no other pathway. Now, if the problem is that another pathway needs to be followed, it needs to be identified, but that pathway doesn't always have to be some sort of holistic chatty therapy. We do need to actually consider medicating our children sometimes when there are significant issues at large, and it's just not viable. We just cannot get it, apart from those that can afford to go private. They go private, they get a very thorough psychiatric assessment, they get the medication they need, and then their lives are transformed. Yet those of us at the mercy of the NHS, our children's lives are not transformed. And then, as all the comments in the comments section in the chat identify, things get worse, then kids just can't function, and then they have trauma-related trauma, and it's a cycle. So that's my bit. Thank you. Less of a question, more of a statement, really, but I just need to know, where are the pathways then if you don't consider things like OCD or Tourette's moderate to severe when they're impacting their lives significantly?
Thank you, Bernie. If we can ask Katie to respond to that. Thank you.
Yeah, thank you, Chris. I'm not very good at putting my digital hand up. I'm sorry, I don't do many Zoom meetings, but I can answer the Tourette's question really easily, Bernadette. We kind of work from a diagnostic manual. The most up-to-date one that we work from is called the ICD-11. And tics and Tourette's don't sit in the mental illness section of the ICD-11. They sit in neurology. So the tics and Tourette's service is offered by our colleagues in community paediatrics. It's not offered by CAMHS or mental health services because it's a neurological condition, not a psychiatric condition.
But so community paediatrics don't know where to refer to then, because they referred to you. But they in one particular case, they do.
They shouldn't, because it's a neurological condition, not a psychiatric one. So we wouldn't pick up tics and Tourette's. I don't know if that's a succinct answer to that bit.
It is helpful, but that's not the path that was followed. So that's actually helpful. But yeah, thank you for that.
And I think you wanted to come in earlier. Did you still want to make a comment?
Yeah, thank you. And apologies because it's jumping back a bit from before what Bernadette was talking about. And really, it was just following up on that question about what counts as moderate to severe, and just to come back on the answer around suicidal ideation. And I suppose whilst recognising that yes, there can be a number of reasons for children to and young people to have suicidal ideation and to talk about it, actually once they're at the point of regularly making serious attempts, and then are referred to CAMHS, I suppose there still seems to be a disparity between what representatives from CAMHS are saying and what parent carers say about whether or not those referrals are accepted. And this isn't about specific things, but I speak to a lot of parent carers and have seen letters where children and young people who are actively making suicide attempts are not accepted, the referrals aren't accepted. And then just to follow up finally, as somebody else has said in the chat as well, that really presenting these children at A&E is surely, if you already know they're making those attempts and that referral has come through, presenting those children at A&E is not the most proactive or patient-centered way of supporting them. So it's just that disparity that there seems to be between what parent carers are saying and what we're seeing in letters, and what the representatives are saying at this meeting. And there must be a way to find our way through that, because not everybody can be completely, it can't all be true, if that makes sense.
Can I come back in on that, Chair?
Yes, you can. Yeah.
Yeah, because I think it's really helpful feedback, and I know, and you know, we've met before, and we've looked at some of that feedback about letters. We are looking to improve what we do and really listen to what people are saying. I think one of the challenges when we think about referrals is that there can be lots of reasons why a child might be behaving in a way that is causing harm to themselves. So there's a lot of evidence or guidance, for example, about children with learning disabilities who might behave in a way that is called self-injury behaviour. So the treatment and support for that child will be very different to a child who has got suicidal thoughts, or for a child who is using that behaviour as a way of communicating something. So there's a range of different reasons. Sometimes what we find is that our referrals that we get don't include all the information that you might think we've had. So one of my pieces of advice would be, if you've made a referral, if you think there's something that we haven't, that we've missed, or that we don't know about, or that you've got questions about why that referral hasn't been accepted, why we think your child won't benefit from a CAMHS service, or why we think you as a young person won't benefit from the CAMHS service, you know, you get in touch and we can have that conversation. Sometimes we ask GPs or referrers to give us more information. And sometimes, you know, the clinical assessment is based on the information that we get. And that information can change. So the information that you might send today might be different than what you might send in a month or so. So I would really encourage people to think about that in terms of referral. Is there anything else we've missed in the comments so far?
Could I just ask Sonia, who can make a referral into CAMHS? Because obviously we know there's big waits for community paediatrics. So those of us who are lucky enough to have paediatricians in our lives, if they can't quite get it right, then or get them in, then that's one barrier. But who else can refer into CAMHS?
So GPs and professionals referring to CAMHS. In Worcestershire, our current wait for an assessment in CAMHS at the average rate is 4 weeks. We then have a longer wait for treatment once we've kind of done that assessment with young people and their parent carer. So it's about 6 months at the moment for treatment in Worcestershire for most conditions. However, if you've got an eating disorder like anorexia nervosa or bulimia nervosa, we're seeing people within the week for urgent cases, within 4 weeks for everybody else. Similarly, crisis care, people are seeing within the 24 hours. So we've got a range of different support. Our mental health support teams are seeing children and young people and also working with the schools to think about how that environment
That's another issue that's been raised on the chat, actually, and especially as a lot of autistic children don't actually have school placement, none at all, or waiting or part-time. They can't actually access most of the support that you might put in place, even in early interventions. So that how are those things being addressed?
So there's a range of support across the system, and it might be if my education colleagues were here or the ICB were here, they'd be able to give you more about that as well. So we have things like CAMHS, which is a free online counselling support service that the ICB have brought in for all children and young people in Worcestershire. It includes kind of chat rooms and information and counselling, one-to-one counselling. We've got Lumen Nova that provides anxiety support for children aged 7 to 12. So again, evidence-based online support. There's Mellow, which the ICB commissioned. It started in April 2025, so it's still in its first year of being with us. But their remit is emotional health and wellbeing support across the board, including for young people with neurodivergence. There's a range of things that they offer, both one-to-one and group. To answer something in the chat, they do have staff trained in evidence-based therapies, as well as offering parenting support, individual support, and group work. There's the family hubs. Again, they're open to everybody. They run a range of groups. They do a lot of signposting, but they work with young people with SEND up to age 25, and they work with all young people up to age 19. They also do bespoke bits of training. There's lots of online things, for example, understanding autism, which are sessions led by young people with autism. There's a range of things across the system. And I know sometimes they're hard to navigate, which is why we've been getting support to help develop our website. And that's had young people and parent carers help us develop that. So that's launching very soon.
That's great. Can we move on to the next question? Because we spent a lot of time on that first question, which is really helpful. But if we could move to the next question, which does sort of move into the areas that you're talking about, Sonia. So there are 2 slides to this question. I will read the first part and then allow you to answer it. Do you think the contract with Mellow effectively and safely fills the gap in mental health services, and does it guarantee no additional risk of increased harm to our children and young people or deaths by suicide? Were considerations given to supporting families and their children and young people in a crisis situation with the risk of suicide being high or imminent whilst waiting for support from Mellow? Do you think it's either viable or fair when these families may have already waited for mental health services? And do you think it is acceptable for families, especially with neurodivergent children and young people, who CAMHS have discriminated against for years, to be left unsupported and often in crisis? And did you consider the influx of referrals and the numbers requiring these services, and the reality is that these families just end up on another long waiting list? Who'd like to answer that one?
I think there is there is strong commissioning element to some of those. And I think luckily Mary's just joined at that point, but I'll perhaps if we talk a little bit, just to give Mary a little bit of time to to catch up with where we're up to. So I think it's generally the approach for commissioning is you consider the population need and look at what services you've got, what the gaps are, and how do you fill those. And more it's about looking more holistically of how services can work together, what's the range of services and what they can offer. I certainly think that since COVID, we have seen there has been a big increase in terms of need. And as a health service, we are still playing catch up a bit. But there are significant investments going into children and young people's services. So it's both within the services that Hereford and Worcester Health and Care Trust run, but also provided by other providers. And it's really incumbent on us as the NHS provider to make sure that we're linking up all of those services, making sure there's no wrong front door, and making sure children and young people are getting to where they really need to be. I mean, in terms of some of the questions here about effectiveness of Mellow, again, the ICB will be overseeing the quality of that provision, and as they do with any provider. I mean, Katie, is there anything that you want to just say in relation to these questions here, or should we invite Mary in?
I think Mary might be best placed rather than myself for this one, Scott.
Okay, colleagues, can you hear me?
Yes, we can, Mary.
You can, that's right. Yeah. I'm not used to Zoom. I can't see that. So obviously we co-produced and worked together with many groups in Worcestershire and Herefordshire about developing Mellow, and we launched it in April last year. And it does provide, we've commissioned that evidence-based therapy and support to children and families. So the waiting time for Mellow and CAMHS assessment, there's been a big reduction in that. So that is 4 weeks or less at the moment. So, you know, the waiting times aren't as long as they were, although demand is continuing to increase, as we say. And as Scott says, what we're working to make sure is that the right child is getting to the right service first time. So there is criteria for these services. It's still relatively new, so we are assessing it and monitoring it, and we're looking at the outcomes of what they're achieving. We're in regular contact with the provider as well. There was in the early days there was some children that probably didn't go to the right place first time, but in recent times that seems to have improved. But we'll bring that back through the SEND committee as a proper report as to what we've seen so far. And I think that was due for the end of the financial year as per our contract agreement. So, you know, if we haven't got it right in the first sort of year of delivery and commissioning, we will adjust that. We will actually be doing that. So, but, you know, some feedback we've had so far from parents has been quite positive since that first few months of settling down the service has happened. But, you know, happy to take people's views as part of the evaluation. I know the team are doing that and have been doing that. So we're happy to hear tonight what people think.
I think there's a couple of questions in there about how was quality overseen, and it's again whether Mary, you want to take that one, or Katie, Sonia, do you want to give a more generic answer around how we oversee quality?
I'm happy to come in with a couple of things, Scott. So I guess in relation to training, I can't speak for the Mellow service, but what I do know from information they've shared previously is that staff have training in a range of therapeutic interventions. So in CBT, for example, in parenting interventions, because for children and young people experiencing emotional mental health distress, part of the solution is supporting their parents or carers to support them at home and to deal with the emotions that they're experiencing. So there's a lot of training that Mellow have about that. And as Mary said, the commissioning required them to be able to demonstrate the evidence-based therapy that they could provide. and to also provide the outcomes. So as we come to the end of this first year, it will be about, the ICB, talking for you, Mary, will be evaluating that first year and how it's going. In relation to CAMHS as well, we do have regular meetings between CAMHS and Mellow, where we focus on children and young people who need support and try and make sure they get to the right place as quickly as possible. So if Mellow are working with a young person who they've got concerns and risks about, they will get consent and talk to us directly about that, enabling them to come over into CAMHS if they need to. Sometimes young people need both the support of Mellow and the support of CAMHS. So we also talk about that. It's not an either or one leads to another. So that also gives some support about safe practice and managing any risk.
I think with it, when you can contract somebody to provide healthcare, they have to have the appropriate registrations. They have to be able to demonstrate people are appropriately trained. You operate to a set of KPIs which demonstrate what you're doing. And then there is subject to, you can be subject to spot checks, reviews, whether that's through the ICB or through the CQC. So those are the kind of things that are in place, and the kind of questions that was asked is about: is it safe? Is it effective? Is it caring? Is it responsible? And is the service well led? And those are the kind of domains that we work to in the NHS, and anybody who's commissioned to provide NHS care.
Thank you. Should we move on to the second part of this question? So I'll read the question as it was given to us. Where do CAMHS suggest an autistic young person goes for essential mental health help, which requires their service? However, the only suggestion is to go to Mellow, who are also recommended in the interim wait for a CAMHS assessment. Why are Mellow suggested as a stopgap and then as the only support, unless they refer to Mind, who are still not CAMHS? An autistic young person needs CAMHS help and support far more than a neurotypical one. This is a very dangerous choice and can easily lead to a young person falling into serious crisis with no appropriate mental health support available. Who would like to answer that, please?
So I can start if you like. I mean, this is really difficult because this sort of feels like this might be somebody may have had a particular child in mind when they wrote these questions. So I want to try to be mindful that, I can't answer in relation to a specific case. But, in answer to the first one, where do CAMHS suggest an autistic young person goes for help which requires their service? Absolutely. If a young person has reasonable suspicion of a moderate or severe mental illness and they happen to be autistic, then they should be under the care of the CAMHS service. And I think, as lots of people have said, we do have, sort of generally about 30% of young people open to our CAMHS service are neurodivergent. Yes, sometimes if we, when we screen, a referral comes in at the single point of access and we perhaps don't see enough evidence of reasonable suspicion of a mental illness reaching our threshold, then we may make a suggestion to go to Mellow, who are, in old-fashioned terms, our sort of tier 2 colleagues. Sometimes we say we might do an assessment for a young person, like an initial appointment or choice appointment as they're called. And because we are mindful of our long wait to partnership, so the intervention, so we'll do an initial assessment, we recognise something needs to happen, but we know there's a long wait until that intervention can happen, then we do sometimes, if we can recognise a smaller piece of work or something that we think could make a real difference to that young person or family in the interim while they're waiting, then we will make an additional referral to Mellow. So as people have said before, it's not as black and white as either or. You can be on the CAMHS waiting list and be receiving support from Mellow. So sometimes we do that, which I guess is maybe why, going on to the third point, Mellow might then be viewed as a bit of a stopgap. So what we are trying to do is we're trying to think of any other service that could offer support, whilst the child is waiting, while we recognise, that there are needs for that young person and their family. I have to be honest, I'm not quite sure what the little bit about mind and who are still not in CAMHS, what that bit specifically means. But coming to that kind of fourth and final point, we absolutely recognise that, there are some young people with autism who do also need that highly specialist CAMHS intervention. And I sincerely hope that we have the vast majority of them who do hit that threshold on our caseload. As I said, we have high numbers. If we think about the kind of general prevalence of autism in the population, we are... young people with autism are overrepresented in our caseload, at 30%. So we definitely do recognise that you can have both. So I hope that's kind of covered most of the 4 points there.
Thank you. Shall we move on to question 3 now? And Debbie's going to go through that.
That's fine. Although this is specific to a certain family, the sort of issues that are within this question are quite typical from what we hear. So it's, what support can I access for my 8-year-old who runs into the road trying to kill himself? Who can help with challenging behaviour towards siblings? What do I do when he's bigger than me and I can no longer restrain him? Family Front Door, Children with Disability Team, CAMHS, CAST and other services have all rejected us. Who will help us before it's too late?
So, thank you. I mean, obviously there's a range of very personal questions there, and obviously, we don't know the circumstances behind these, so we'll only be able to speak very generically, both between health services and council-funded services. There are a lot of services out there that we have talked about which do meet other needs, but also recognise it can be frustrating where people don't feel they're getting the support that they need. Recognise it's a challenge, but as a health service, we are, as Mary's talked about, there is a wide range of commissioning around additional services and support. The council's got some money, which for those of you who sit on various boards, the toucan money, again, that support that will help some of the presentations perhaps described here. I think so. Really, it's more about we, as a health and care service and system, we're committed to trying to help as many people as possible. I mean, I don't know whether Mary or Sonia, Mary, do you want to add anything to that? Or
I mean, I think as a general point on CAMHS, because it sort of links that, as you say, that if this individual was rejected by that, I think most people know we've done a deep dive on the CAMHS service, and we're working on producing. You said we did document that shows our response to that at the moment. It'll be coming back through the committee shortly. I mean, I just would, if this is a case that's active now, this child's in distress now, that that accessing immediate care or through the GP is the best way to go, is the best way to make sure that child's safe at the moment. But we've heard other similar stories. We do acknowledge that. That's why we've done the review of CAMHS services, and you'll be getting that report shortly.
Could I just raise, though, Mary, that with that question in particular, this person has obviously tried to access a variety of methods and support interventions, none of which have been forthcoming. So it's really difficult as a SEND parent carer to navigate every single thing we have to navigate,
I appreciate
right?
that.
So that parent in particular must have been at her wit's end, dealing with all of those different services and still getting rejections. We know how closely connected the disability with social care team needs to be with health, and especially if a child ends up with an EHCP, it's an integral part of their EHCP, which is often overlooked. But what's happening to the children that are just falling through the gaps? This is the problem. there are so many gaps, and then just that little list on that slide there, there's no reason why that person should be in this situation.
Oh, I would also add, we hear a lot from families who are in similar situations to this, where they go to their GP and the GP, apart from CAMHS, doesn't know where to refer these children to. So again, you know what I mean, the GPs, I sense, feel very frustrated because they often say to parents, you won't hit the criteria for CAMHS, but we don't know what the criteria is because
And
it's
they're
not
just
published.
batted between different
Yeah,
services. And like that's an example there. Family front door might say, oh, it's a mental health need. And then you might go to mental health and then it's not a mental health need. You know, sort of go around in circles then, don't they?
It is that. I think just being really, really think, I recognise that it can be really challenging navigating between the services. And for when we're working really closely with Mary's teams around developing 3-year plans, so that we're really, really designing where it is we want to get to and how we're going to get there over the next 3 years. So there's a neurodivergent one which is coming together, and also there'll be a paediatrics one as well. And again, we will share these plans with through the various groups. It is really important in those plans that we so how we support navigation of the system. That's one of the things in my mind. How do we make it easy to book in and get your appointment? How do you avoid being passed between services? So these are all the things which are in my mind when we're designing our services, and how we can provide that best possible service within the money we've got. So yeah, and I recognise that there will be people on the screen, their colleagues on the screen, who'll sit there and will be frustrated that they experience this now. The assurance I can give you is for those people experiencing that, we have heard and we are working to join our services up as well as best as possible and get the best possible experience.
What we will do, though, as a result of this is because we do training with the GPs on all of this. So I will take that away as an action and work with the GPs again to understand exactly what their frustrations are. The information is available. Remind them where that information is. And we'll feed that back through the SEND committee as the outcomes of that. Okay.
Chris.
One of the other things in the chat is I think this is driving parents of patients to actually go down the private route in order to actually get their children looked after, and that is causing issues. Could you address that, please?
Do we mean in relation to CAMHS or to general neurodiversity assessments?
Okay, so I'll read the note here from Karen. We have a growing 2-tier system which is inequitable and exacerbates disadvantaged. Parents who can pay go private are forced to do so, but many parents haven't got the resources to do this.
Okay, so if it's related to neurodiversity assessments, I can outline that one. It builds on what Scott's just gone through.
As this is to do with CAMHS, I'm suspecting that Karen probably means psychiatric, because whilst that does count to both both neurodivergence assessments and psychiatric, we're referring to accessing mental health support within this conversation. So right. I'm assuming that that's what we're talking about. And actually, as Parent Carer Forum as well, we know of lots of families that can't access NHS support, and I did refer to this before you joined the call, Mary, where people are having to go to private psychiatric assessments, which are costly. Then the continued care for that is costly, and they are actually getting medicated where the NHS won't do that, because you cannot access a psychiatrist for quite bog standard, like low-level medication. But that's
Karen
the problem.
has confirmed that is what she's relating to, is the mental health side.
So you've got people paying for antipsychotics for their 10-year-old children, and it transforms their life where they couldn't do anything, and then all of a sudden they now can. And yet you've got a similar age child that can't access that same care, and their life is in the hands of the NHS.
Okay, I think that's something we'll have to take away and discuss. I wasn't aware that a lot of children are going to get private psychiatric care. I knew there were for neurodiversity assessments, but not private psychiatric care. Scott or Kate, were you aware of that?
No.
No. Okay, we'll take that away and come back through that committee with that one.
Lee, you've got your hand up. Would you like to?
Yeah, I was just going to say, as the Thundercroft does offer clinical therapeutic interventions. This is just an observation. So obviously we have had a massive influx of adults and children coming through into our services with multiple, trauma related. We talk very much about the neurodivergent, but we've also got domestic and sexual abuse and mental health. Suicide ideation is commonplace here. And it's just to let you know, if we are talking just to children, even though the child won't be the primary person we're talking now, I can tell you now, as a frontline organisation, it's very rarely to us just that one child. Then before we know it, we've got the parents. Parents are seeking counselling because of the baby at home. We've then obviously got siblings, whether they are, again, start to identify with similar, and sometimes it's just because of the behaviour, because of the family dynamics. So whenever we talk about a child, lots of times I think people don't realise that actually the fallout is family-wide. There's not many instances, I feel, where we are. And again, the thing when someone mentioned earlier about having trained staff, I do have children therapeutic counsellors here, obviously not the same way as I do adults. And we do have a certain amount come through, and we have to keep trying to prioritise trauma work because it's more specialist, even though we can work across the board. But it's quite surprising how many parents come through and they are desperate for what they class as clinicians, and that do have obviously the training to do it. But if we open it too much, when we do, sometimes we're absolutely swamped. So we obviously have to keep it very tight. But the amount of people that come to us and are, again, what the lady's saying there, paying for therapeutic counselling for their children, there's a lot. So obviously we see that here because obviously they come to us to buy it from us, which obviously, we try as much as possible to put it through the free counselling, but lots of times we're not able to meet that demand. So, but there are, even today, I met a parent that is paying for 3 of her own children individually to have therapeutic counselling. She's come to us because she's heard that we offer free counselling and begging me to see what I can do because she's desperate. Which child does she give it up? Because she can't afford all 3.
Yeah. Thank you. We are sort of running out of time, so I've got an eye on the clock. Anne, would you like to come in briefly?
Yeah, very briefly. I want to back up exactly what Bernadette has said, and actually Lee. I have sat in meetings with some of the colleagues on this call where this has been talked about very openly, the fact that parent carers are paying for psychiatric support for their neurodivergent children because they have been turned away by CAMHS at triage or at other points. And quite often they're being seen by and paying to be seen by privately by clinicians who are working within our own CAMHS services or have worked in them in the past. It is a real problem and it is an absolute 2-tier system, and we should be ashamed of it as a county.
Okay, thank you. Can we move on to question 4? And we'll try and deal with that question before we end this meeting.
Okay, I know that CAMHS in Worcestershire are not commissioned to diagnose or treat ARFID, which is avoidant restrictive food intake disorder, but where are the parents supposed to go for assessment and treatment instead? Dietetics cannot diagnose and they can only vaguely advise. Are there any plans to publish the findings of the recent deep dive into CAMHS and any actions that are going to happen from the findings?
I'll happily take the first question. So in recent month, 6 weeks, I've had 2 cases escalated to me of ARFIDs. Our chief medical officer is working with the specialised commissioners regionally to see what we can access. It is quite limited across the country, apparently, and there are very, very long waiting lists. So we're working with those specialised commissioners because we have not got that specialised skill in our county at all. And Birmingham, being the closest, has got quite a very small team apparently. And again, they've told us in the last 2 years the demand has grown significantly. So again, we are bringing this back through the committee when we've got an outcome of what we can do to meet the demand. But the 2 cases that I've escalated to, we're focusing on those 2 cases first.
I'm confused a little bit about the comments earlier on about eating disorders, anorexia and bulimia being seen within 1 week, if it's an urgent case, when actually some of our kids with ARFID are expressing the same sorts of behaviours. And of course, some of it is, I'm not going to get into the sort of the medical side of ARFID and fussy eating and restrictive patterns of behaviour and then anorexia and bulimia. But as somebody with lived experience of a variety of those issues, I'm kind of concerned as to where the line is drawn and where you would sort of say, okay, this child's not eating because it's autism and they've got a sensory issue or whatever it might be. To then go, okay, now we need to see this child because they've got a moderate to severe mental illness.
Shall I come in for that one? So I think you're right, Benny. You really highlight there are a range of reasons that a young person or a child might have problems with their eating or their feeding. So we have certain conditions like anorexia nervosa and bulimia nervosa, which are really identified as mental health illnesses, mental health conditions, and there are evidence-based treatments that CAMHS offer to help that child recover from that illness. Anorexia nervosa is one of the most risky mental health presentations that we have and can lead to a child having significant physical health risks driven by their mental health need. So we have got a specialist eating disorder team in CAMHS that works with those young people and their families, and we're really delighted we have got some additional investment to grow that from the region coming in to provide intensive support for children at home. We don't often use mental health inpatient units. It's something that we've been applauded for across the region and actually asked to present in other areas about. So we have a real strength at supporting people at home, and we're building on that to do more of that for eating disorders. Restrictive food intake disorder is a feeding disorder, and it can come from a variety of things. So it can be about a sensory response to food and textures. It can be a child has experienced choking and they've got real challenges there. Each child with a food restriction will have a different range of needs will need something different to help them with that. So I'd really encourage people to talk to their health visitor. Sometimes this can start in infancy. Talk to your health visitor, talk to your GP about the kind of support available. There are a very small number of children nationally who would need an ARFID service. Now that has different professionals in it than a CAMHS service would have. And you want a different type of intervention than something like anorexia because it's driven by different things. So that's the times that we then might refer people to a specialist service in Birmingham that Mary was talking about earlier.
Can I just reference the bulimia thing, because I was raising OCD earlier on, and often with autistic people, bulimia and OCD, they're a sort of very connected thing. So maybe that's a conversation for another time. I'm just wondering if there's more funding going into eating disorders and then bulimia not anorexia being a different sort of, well, it's different, obviously a different sort of eating disorder with different kinds of reasons and different kinds of triggers. I'm just wondering where that sits. And just in terms of the comments, I was not referring to the antipsychotics being low level medication. There was 2 different examples that I was giving. i.e. getting low-level medications, and then I know families that are also then going and getting antipsychotics.
So the evidence-based treatment, just to answer the anorexia nervosa question, the evidence-based treatment for something like anorexia and bulimia nervosa, there's a lot of research done that shows that that can come from a range of different places. So you have some young people who have restricted their eating because they wanted to lose weight, and then they've developed cognitions that are around anorexia. You have some young people who maybe have perfectionist traits or high achieving traits. You have some young people who've experienced a trauma, and you have some young people who've got autism or neurodivergence, and that's part of what's impacting on their anorexia nervosa. So that the treatments that people are trained in to deliver in CAMHS for that do take account of that. So if you're a young person with autism and anorexia nervosa, and your anorexia is driven by your autism, that the treatment modality will adapt around that. Bernadette, so hopefully that answers that question.
Thank you.
If I could just, thank you, Don. If I could just come in here, we will save all the comments, and as a team, we're going to go back and look at them, put them into themes, and ask the speakers if they wouldn't mind responding to those that we've not been able to answer so far, because obviously there's a lot in there, and we don't want to miss the rich kind of mixture of feedback that we've got tonight. If that's okay with Scott and Mary, is that okay?
Yeah, that's absolutely fine. You're happy to do that.
Thank you. Back to you, Don.
Are there any more responses from that? Did Scott want to come in?
No, I mean, I think I'd just say thank you for inviting us along tonight. Yeah. We're always happy to talk about services, and we're very committed to working with parents and carers to develop our services further. We've gone over some really quite complex topics tonight, and whilst perhaps some of the answers of people feel we're not providing the full service that we need to. We work very, very hard with commissioners to close any commissioning gaps and meet the needs of people. But I think overall, we've heard there's an awful lot of services provided for children and young people, and we're working very hard to make sure they're joined up and can provide the support that's required. But overall, just really thank you for inviting us, and I'm sure we'll see many of you again at an alternative forum.
And can I say thank you to Scott, Sonia, Katie, and Marie for coming along this evening and answering all of our questions. Thank you for those who've submitted their questions. Thank you for all of the comments, and as Chris has said, we will try and get responses to those that haven't been responded to. Can I also ask at sort of any members of the public who have got issues to feed your experiences into Healthwatch Worcestershire? We're always interested to hear what's going on, and we will respond appropriately to all the responses that we receive. I think that concludes our meeting for this evening, and thank you for everybody who's attended, thank you.